Okay. So, what we were talking about last time is we said that in order to understand the urinary system, to understand how it does its job, most of us coming into it would assume that it would just be this filtration process like we were talking about. So, and that's certainly a very important one, right? We said that it's occurring up there in that ball of capillary. And what's that ball of capillary called? Yeah, glomerulus. Very good. You're like, I don't know, as long as I know how to spell it, that's what's important. It's not an oral test, that's for sure. Okay, so we have the glomerulus. So that's a specialized ball of capillary that we see there. And like the other capillaries that we saw in the cardiovascular system, it's going to have filtration. Things are going to be pushed out of it because of hydrostatic pressure, blood pressure that's constantly new blood that's showing up into it, and the blood either has to go straight through and exit the capillary, or it can be pushed out like the coffee filter like we keep talking about. Now, one of the differences that we'll see is, and we referenced this last time, is that with a regular capillary, it was about exchange. So we were filtering things out, and then through osmotic pressure, we were sucking it back in by the end of the capillary. That's something that is a little bit different here. So in this case, we only have filtration occurring at that ball of capillaries that we call the glomerulus, and anything that is going back is occurring later on, like it's a proximal convoluted tubule and the nephron loop, that long loop that extends down to the medulla of the kidney, or the distal convoluted tubule, etc. And so that we term reabsorption, and it's the second key process that occurs within these nephrons in the kidney in order to make urine. But like we said, it's not occurring at the glomerulus, it's occurring between these, what are called paratubular capillaries, and the rest of these other tubular segments of the nephron. Okay? So we call that reabsorption because we absorbed it already first in the intestine, and so now we're getting it back again. Our third key process was secretion. So this is where we can put other things out of the blood into the tubules, into the filtrate, into what will become the urine, in order to get rid of them out of the body. Okay? Okay, so all three of those are going to be very, very important. And so we're going to talk about them in turn, about where they occur, what are some examples of ions or molecules that are being moved according to those different processes, and just get into a little bit of the detail, the actual mechanisms of them, in order to understand what's going on. Now, while we're looking at this figure, one of the things that we can see, even from the simplified figure of a nephron, is that in essence we have two different capillaries in. We have this capillary bed, which is going to be the glomerulus, and then we have these paratubular capillaries that are wrapping all the other tubules of the nephron. And so it's kind of weird because when we start out going into the nephron, we have an afferent arteriole. And usually we have an arteriole going into a capillary, going into a venule, and then going into a vein, right? So the capillaries are between an arteriole and a venule. But if you look here, we have an afferent arteriole going into the glomerulus and an efferent arteriole coming out. So that's another unique aspect about this capillary bed, the glomerulus, is not only is it only filtration, it's only outward movement, but it occurs between two arterioles as opposed to between an arteriole and a venule. So we go to the efferent arteriole, exiting the glomerulus, then we go to the paratubular capillaries. Then finally, these one that going into venules and veins and stuff like that. Okay? So we have two capillaries of bed that both are very important in terms of the nephron function. Okay. So let's start with the first one, the glomerular filtration. So we've been talking about this a little bit. We said that this is going to be the movement of fluid, like water, as well as solute things that are dissolved within the water, out of the glomerular capillaries. So because this is a size-selective process, basically, if it fits through the holes, it's going to drop into the surrounding coffee pot that we call the glomerular capsule. If it's too big, it's going to stay within the blood vessels instead. And in fact, we have what's called a filtration membrane. So when we look at it, it's almost as if, if you think about the glomerular capillaries, or the glomerulus as, well, almost like the heart in a way. Remember that the heart had membranes associated with it. It had a visceral pericardium on the surface of it, and then it had a parietal pericardium that was lining the cavity, the pericardial cavity, right? Two membranes. And if you followed those around, you would find that the visceral pericardium would actually go right into the parietal pericardium. So it'd be parietal pericardium out here, and then visceral pericardium when it's on the surface of the heart. And it's a bit the same with the glomerulus. So the glomerular capsule that we've been talking about, which is in essence kind of a coffee pot, is basically the the parietal membrane of the glomerular capsule. But there's also a visceral layer to it as well. So when we look at that ball of capillaries in the center there, we can see that there's a yellow layer on the top of it. And the yellow layer is going to be the visceral layer of the bone of the capsule, and it helps to form this filtration membrane. And over on the right side of the figure, where you see that yellow, you can see these podocytes, these foot cells that kind of interfectate, if you will, with each other. They kind of interlace with each other, so that they create small holes that things can pass through, but we make sure that big things are going to stay in. So when things are getting filtered out, they have to go through the wall of the capillary. They can have little holes that are called fenestrations. Fenestra is the word for window, like in French. And so, in fact, there's a word, an English word that's called defenestrate. So when you see somebody, they're driving along, and they take their cigarette butt and go out the window, which is really annoying, right? What's that? They don't want to get in their car because it stinks up their car? Yeah, well, you made it, so you have to suffer. Why don't we have to have it? Anyway, that's called defenestration. You're basically throwing something out of a window. So those are called fenestrations. In fact, the walls of the epithelial cells making up the capillary have small holes in them that, again, help to make the stem or colander or something like that, making sure that small things can get through, but big things stay in. So there's multiple layers to this filtration membrane that we see here. Some from the glomerular capsule, like we see in yellow with those podocytes, and some just due to the wall of the capillary itself. Okay? Excuse me. So that's where our filtration is occurring. All right. Now we said that these capillaries are unique because it's all going to be outward movement filtration and no movement back in, no reabsorption. And the reason for that, in a way, is similar to what we saw before. It's going to be hydrostatic pressure. The fact that there's always going to be more blood showing up there and pushing these items through. But the thing that's different in terms of the glomerular capillaries compared to other capillaries like systemic capillaries, etc., is the diameter of the afferent arteriole coming in compared to the efferent arteriole coming out. Okay? So you see the tube that's leading into it here is much bigger than the drain, if you will, that's leading out of it. So what that does is it creates a backup. It creates a backup right in the glomerulus, right in there, because there's always more arriving that can be drained out of it. And the example that I usually use for that comes from my sister-in-law's house. So a lot of my in-laws live in Hermosa Beach and Redondo Beach, so during the summer we usually spend a week over at the beach there. And we stay with them, and they have in their guest bathroom one of those shower tub combinations, right? So with the shower tub combination, you've got the shower head, that's the input, that's the inflow right there, right? And then the drain at the bottom is going to be the outflow. And depending on the rate of inflow and outflow, if you have a clogged drain down there, because it has air and stuff like that, right? Then what you get is you get a combination shower bath while you're in there, right? You're taking a shower, but you're in your ankles, deep water, or something like that, because it's not able to drain it fast enough. Now, luckily at her house, right, it's not just the one control like this. It's got two controls for hot and cold, so you can actually dial down the pressure. So when I'm taking a shower there, that's what I do. Knowing that the drain is going slowly, I take down the inflow so that the drain can keep up. And that way I'm not standing in the bath as I'm taking a shower, right? So by adjusting the inflow, then that adjusts the amount of backup that can be in the bathtub. In this case, we have an inflow and an outflow, and the bathtub is kind of like the glomerulus. And that inflow is always bigger than the outflow. And by keeping it that way, it creates that backup in the glomerulus, which gives us enough blood pressure to make sure that we're always pushing things out. So there's so much force, much higher than regular capillary does. There's so much force from the hydrostatic pressure that is always winning. We're always pushing stuff out of there. and it's so forceful going out, there's not a chance for anything to be pulled back in due to osmotic pressure or whatever. There is osmotic pressure there, but like we said, there's such a higher force pushing out that it always wins, and we always filter here at the glomerular capillaries. Okay? Now it's kind of interesting because the body, through sympathetic control and stuff like that, we can actually adjust the diameter of the afferent and the efferent arteriole, just like I was talking about doing in the shower. And that way, you can maintain the pressure in the glomerulus. So regardless about what's going on in all the other aspects of the cardiovascular system, if the blood pressure is high or blood pressure is low, like we were talking about before, we can make sure that the kidneys are able to do their job and control it locally and say, okay, even though you got low blood pressure going out there slightly low because you're dehydrated or something like that, we got to make sure that the kidneys are able to do their job, otherwise these toxins accumulate, etc. So we're always going to be maintaining that glomerular filtration rate by adjusting this inflow and outflow like that. So it's a little localized control method like that. Okay, so in essence, I wouldn't worry about all these things that we see here. So what it's saying here is that we have all these different pressures involved, some of them going out, some of them going in. But we said that in truth, that blood filtration pressure, right, that blood hydrostatic pressure, HP, is so high, it basically cancels out or overcomes any of these other ones as well, okay? So that way, we can make sure that we always have enough filtration pressure to make sure that the kidneys are able to do their job, okay? And these ones just say, in essence, if we change the outflow, this is efferent, right? If we constrict that, it's going to cause more of a backup, there's going to be more filtration that's going to occur. So we can make sure that we can control that locally like that. Okay, we also said that these are very efficient filtration machines. We said that they can filter about 125 milliliters per minute. That translates to about 180 liters in 24 hours. And we highlighted the fact that we only have 5 liters of blood. So we said that if it was only filtration, which is kind of what we thought going into this, that's how the kidneys work, we filter stuff out, which is true, but if it was only that, we said that we filter through all of our fluid in the body in very short order. And so we are going to need that reabsorption, that second critical process, in order to maintain fluid balance, etc., in the body. Okay? Okay. So we said that autonomic nervous system, particularly sympathetic nervous system, is going to be able to control that on a regular basis to make sure that the filtration rate stays relatively constant. There's also another mechanism that the body can utilize in order to help maintain filtration as well as blood pressure, etc. Now we're not going to get into a lot of details of it, but we mentioned early on that the kidneys put out a couple different chemicals. They put out erythropoietin to control red blood cell production, and also puts out this chemical, which is called renin. And renin is part of what's called a RAS mechanism, R-A-A-S, okay? So that's the renin part. This is angiotensin, like you see here, and this other A is aldosterone. And so the aldosterone, the angiotensin that we see, that second A, the renin causes the release and activation of the angiotensin. The angiotensin causes the release of that aldosterone, like we mentioned before. And aldosterone controls the amount of sodium that we will reabsorb, and so that helps us to regulate the amount of sodium, which also helps to control the amount of fluids that we'll need to maintain in the body. So this is just another mechanism that is helping us to regulate fluid levels in the body. Not only does the renin affect filtration rate, or it can as a local chemical, but it also can control the release of aldosterone, which is going to help us to control fluids as well. Okay? So I wouldn't get into a lot of the detail. Don't worry about a lot of the detail about that. Just know that the RAS mechanism, like we said, it causes the release of aldosterone and helps to hold on to sodium, and can also help us to control filtration rate. So don't worry about the details that kind of like we see in here. We've got enough other things to worry about. And this figure here just shows us how some of these different control mechanisms work. Where we see, in this case, we see that for instance, the blood pressure, you see the upper left-hand corner, the blood volume, the blood pressure, and the sodium levels have gone down. And so because we have sensed that, we're going to activate this mechanism. So you can see from the kidney, we see the renin coming out. We see it activating the angiotensin, ultimately causing the release of aldosterone from the adrenal glands, which sit on top of the kidneys. And the aldosterone tells the kidneys to conserve sodium. The sodium draws in the extra water. When we draw in the extra water, now this problem where we had low blood volume and low blood pressure is now becoming fixed. Okay? So again, it's one of our feedback mechanisms that can help us to maintain fluid volume and fluid pressure in the body. It also has other effects. So vasopressin is another name for antidiuretic hormones. So we said antidiuretic hormones is our no-P hormone, so it comes into play along this. It stimulates thirst centers in the brain, so we're going to increase our fluid intake, which will help with this situation too. And then it also acts as a vasoconstrictor. So as we constrict those blood vessels, the pressure is going to go up. All these things are going to help us to solve that initial situation. Okay, so the point is, we said that the first step in this process is glomerular filtration. We said glomerular filtration, according to the name, occurs in the glomerulus. It filters out all kinds of things that we don't want and things that we do want. It's very good at its job. We said that it is occurring in the glomerular capillaries. We said that it's that higher hydrostatic pressure that causes it to occur, so we always have this net outward movement from the blood like that. Okay, so that's one of three. Second one is tubular reabsorption. So if you slowly read that name, that says we're absorbing again from the tubules. So we're taking materials like water that have been filtered out, we're taking them from the tubules and putting them back into the capillaries, back into the cardiovascular system. Okay? Now the interesting thing, there's very interesting things of tubular reabsorption, but tubular reabsorption occurs in a lot of different places. So again, here is where our filtration is first occurring. Then that filtration is going into a proximal convoluted tubule, a loop of Henle, a distal convoluted tubule, and finally this collecting duct or collecting tubule. It makes sense, if you will, that this filtrate can be produced up in the glomerulus and is collected in the glomerular capsule. It has a lot of stuff in there that we want to get back. We want to do that as soon as we can. And so the proximal convoluted tubule right there is one of the major sites for reabsorption. We want to get that water back that we're worried about losing, the glucose and the sodium and the amino acids, all these things that we worked hard at making in the digestive system or getting in the digestive system. So the proximal convoluted tubule is one of the primary areas where we do this reabsorption. But it also occurs in the loop, also occurs in the distal convoluted tubule and in the collecting duct. But this figure shows us when we look at the cells that line all these different tubules, we see the proximal convoluted tubule cells are a little bit different because they have these microvilli on their apical surface, on the surface up by where the filtrate is. And just like we saw in the intestine, the more windy the tube, the more surface area we have because of all these little projections, the more places we have to be able to pull things in. And that's the idea there. So the proximal convoluted tubule is one of our most important sites for reabsorption. And it has much more surface area to be able to do that as well. Okay? Okay. Now, another interesting thing about it is that the reabsorption that we do in any of these areas is it's basically called selective and variable. So you look at that and you're like, okay, selective. That means that this is where we get to choose what we're going to pull back. Filtration is all about size, right? Small things get pushed through, big things stay, and that's it. Now we're choosing. We're saying, oh, okay, well, we're going to let that excess water go, but we need to get some of it back. We're going to try to pull this glucose back, etc. So that's the selective part. The variable part seems a little bit weird. This variable, you're like, I don't get that. It should be constant, right? If we're worried about getting these things back, it should be constant. We don't want it to work sometimes and not work other times. But the variable part means, right, especially if you think about for water, it all depends on your input as to what your output should be. So in terms of being variable, if you're well hydrated and you're drinking a lot, you're going to be feeding a lot because it needs to be in balance. A lot of input, we need a lot of output, so we stay at the same set point. If you're not drinking a lot and you're not going to be feeding as much, again, you're seeing a matching of input and output, so you're at the set point. So that's the variable part of it. Based on the bodily demand, it might be hydrated. Okay, we're going to try to suck back as much water as we can, right? And we can get up to 99% of that water that gets filtered, we can actually reabsorb it back and not lose it, okay? But if you're well hydrated, on the one hand, it always seems like a good thing, which it can be, but if you were drinking all this fluid and you were just letting it accumulate and you weren't getting rid of it, well, now you're making trouble for yourself again because you're adding volume, now your blood volume is going up, your blood pressure is going up, and you're putting a strain on the system. So it's equally important that we get rid of excess as well, okay? So in that case, maybe we want to get rid of, we get back 80% of that water, and we let that excess 20% go, so we can make sure that we stay in balance. So that's the variable part. It depends on the condition of the body, and it depends on what the particular solute is. Some of those things we really want back, and some of those things, yeah, we want to let those go. So that's the variable part of it, okay? So when we look at the rates, some example rates of how well we reabsorb things, you can see it's a pretty efficient system, right? We can see 124 out of 125 milliliters we can get back. That's 99% of the water if we need to. It's 100% of the glucose. So glucose tends to get filtered out because it's a small molecule, but our reabsorption rates are basically spot on, that we can get back 100% of it if it's within normal levels. So generally, your glucose levels should be less than about 200, let's say, micrograms per milliliter, something like that. And it shouldn't get above that because we have different ways of controlling glucose levels, right? We said insulin and glucagon are helping to control free glucose levels. Now, if you have just pounded a very sweet, like, mocha from Starbucks or something like that, your influx of sugar probably is going to even overwhelm the system. We've got these transport molecules that are working to bring glucose back in, but if there's so much of it flowing through those tubes, through those capillaries and tubes, there's going to be so much that we can't get all of it. So you may actually find some showing up in the urine. So usually, if we're at normal levels for glucose, like this is not a whack, I'm not diabetic, I'm not eating straight sugar like after Halloween or something like that, then we reabsorb 100% of the glucose that gets filtered to get it back. And this can be, if we look at salt, it can be almost as efficient for salt. If we need to get the sodium back and things like that, chloride, etc., we can do that. Now, depending on the molecule that we're reabsorbing, it will be, the mechanism is different. So osmosis is always going to be just the movement of water from high to low concentration. So we don't need assistance there generally. But we'll find out that we can get some assistance even with water. Other things like glucose and amino acids, those nutrients are moved across via active transport. They're important enough that we burn ATP to shove them across the membrane back into the capillaries. Okay? So it all depends on what it is as to how we get it back. Things like sodium, we'll use active transport to pull that across. Chloride, which is a negatively charged ion, will actually just follow the sodium because it's positively charged. So the positively charged sodium goes that way, the negatively charged chloride follows it, just diffuses it in that way. But anytime we have carrier proteins, whether it's facilitated transport or active transport or whatever, those carrier proteins can get overwhelmed. So like I said for glucose, if we have so much glucose in the blood, those carrier proteins are doing all they can to pull it across, but some of it's going to get by, right? So it's like, there's a, once upon a time there was a show called I Love Lucy, and the characters working in this candy factory, and they were working in a station where they were supposed to like package up the candy and stuff like that. And somebody hits the lever, and they start really coming back at them. And they can't keep up, they're like shoving it down their shirt, and eating it and stuff like that, and it's getting past them. So in essence, the transport molecules in these tubules, etc., can get overwhelmed like that because there's so much glucose, and then the glucose will show up in the urine. So Interestingly, there's one time I was watching like Law and Order SVU, and there was a crime scene where the guy who had committed the murder had to go pee afterwards, and he used the toilet at the crime scene, right? And so he's a guy, right? And so it gets all over the place, etc. And so what they did is they tested the urine, and they found out there was glucose in the urine. So they found out this guy was a diabetic. So when they started looking at their different candidates, they were able to kind of narrow it down to the diabetics, etc. So it's very relevant information that you're learning here to help you in your cases later on. But for the most part, our systems for reabsorption are really, really effective in terms of pulling these things that got filtered out and pulling them back into the blood. Okay? So like I said, water, sodium, glucose, things like that are going to be pulled across. Okay? Now, we said that for the most part, water just moves across as it normally will. It moves across via osmosis. But what we find is that in the last tubular segments, in the distal convoluted tubule, which is sometimes abbreviated DCT, and the collecting duct, that very last tree-like segment coming down, in those segments, they are specialized where they have cells that are receptive to that anti-diuretic hormone, ADH. And what happens there is we're reabsorbing water in the postural convoluted tubule, in the lubricantly, etc. And that water that we're getting back at like 80% is what we have to get back so that we're not dry out costs. Okay? After we get that 80% back, then we're at the optional level, right? It depends on how much input we have coming in, how much output, etc. Then we want those to be in balance. So that remaining 20%, we have under what's called hormonal control. So if we are well hydrated, then we're going to basically just let that 20% go. We got 80% back so that we stay in balance. Looks like we're having a lot of input, so we can let that extra 20% go. But if we're somewhat dehydrated, what happens is we release the anti-diuretic hormone from the pituitary gland, like we learned way back then. It goes down to these last two segments, and it tells them to insert these little pores called aquapores. It's a pretty straightforward name, right? These water pores in the cells along the last two segments. And if we insert these pores, it actually gives the water channels to be able to be reabsorbed even more. So we can get back that extra 20% so that we're getting back almost 99% of the water that originally got filtered. So that's if we're dehydrated. So if we're dehydrated, we're going to insert those channels along the last segments. We're going to pull in extra water so that we can try to maintain our fluid levels in the body. So that part is kind of the, like I said, the variable part of our water reabsorption. It all depends on whether we need it or not. Okay? Okay, and we'll see that coming up in a kind of summary figure. The last thing that we consider when we're looking at different molecules and ions that are going to be moved this way and that is we look at things like urea, uric acid. We'll talk about hydrogen ions and potassium as well. In fact, these are some of the waste products that we're looking to get rid of. So urea is a byproduct of amino acid metabolism. So when you're breaking down protein and stuff like that, like any type of factory, there's going to be the product you want, and then there's going to be some byproducts, okay? So urea is something that we have to get rid of. Uric acid is a byproduct of nucleic acid metabolism. And so you don't want to have to keep it close, that's different. So in either case, we want to get rid of these two molecules. And so these are things that we are going to work at filtering out. We're going to excrete them, etc. The wacky thing is that some of this actually comes back to us. You know, when we're reabsorbing the water along the way, well, we have to do that so we're not dry out hot. But as we're pulling the water out of the tubule, what happens is that the filtrate itself becomes very concentrated. There's not a lot of water there. There's like a lot of urea left in there. And so there becomes a concentration gradient for like urea and uric acid. There's a lot of urea like in the filtrate, in the tube, and not much in the blood. So it actually starts diffusing and kind of following the water. Now some of it comes back, about 50% of it comes back actually. And on one hand you're like, ooh, that's not very good. We're getting half of this waste product back into the blood. But it's it's basically kind of a necessary evil. It's so necessary and important for us to pull that water back, and we get rid of enough urea, we get rid of half of our urea on a regular basis as we're filtering these things out, that we're still getting rid of those waste products at a fine enough level and balancing it with getting that water back. That's an efficient enough system that we're willing to make that sacrifice, if you will. So anyway, the point here is that these are two of the waste products that we're looking to get rid of inside of the urea. Inside of the urine. It's urea and uric acid. Okay. So we have filtration, we have reabsorption, and now we have the third one, which is secretion. Now secretion is pretty easy, okay? We have reabsorption is where it's in the filtrate and we want to get it back. So we take it from the filtrate and put it back in the blood. Secretion is the opposite, like we saw in that little movie, right? So say there's some, ion or molecule or something like that that we filtered out, but we want to get rid of even more. So say it's like hydrogen ions or something like that. That's a common one. We're getting to an imbalance in terms of our pH. We're getting too acidic. We've gone into what's called acidosis for whatever reason. Maybe our lungs aren't working very well because they have a role to play in pH or something like that. Maybe our metabolism is off. The urinary system is one of the few places that we can not only, we talk about finding out hydrogen ions like buffers and stuff like that. Well, that's temporarily, finds us with hydrogen, changes the pH, but in the urinary system, in the kidneys, it's the only place in the body where we can actually take those hydrogen ions and just kick them totally out of the body. We push them into the urine, and now that hydrogen ion is out of the body. So that's a very significant way of bringing our pH back to where it should be. So, tubular secretion is where we're pushing things out of the blood, and we're transporting them into the filtrate so that we can get rid of them. So different types of organic compounds, hydrogen ions, and even potassium ions are common things that we will secrete from the blood and push into the filtrate so that we can get it out of the body. Okay, so this is the figure that I was talking about. This figure here kind of shows us our nephron spread out in the liquid work, and it shows the different segments of it. And what it shows us is it gives us different examples of molecules or ions that are either being reabsorbed or secreted. And so you can see in that first segment there, the proximal convoluted tubule, there's a lot of things that we will reabsorb because that's the primary area for reabsorption. So any of those areas that you see coming from the tubule and leading out the tubule, so going back to the blood, that's reabsorption. So we see water there. We see bicarbonate ions, that's the first one, HCO3. We see sodium there, nutrients like glucose and amino acids and things like that, and either potassium. Okay? Those areas that are going into the proximal tubule, hydrogen ions and that's ammonium ions. Those things are things that we are secreting into it. When we look at the leukocyte here, we see more water reabsorption. That's actually driven by sodium reabsorption on the other side. So as we reabsorb sodium here, the water tends to fall away. Even though this is a big figure, it looks like these two sides of the loop are far away from each other. You got to remember that there's 1 million of these per kidney. These loops are right next to one another. So if we pull out sodium over here, the water sees it and follows it. Okay? So that's really the importance of this loop there. The importance of the loop is it helps us to get that water back. Okay? And it helps to create a concentration gradient here where we can actually use it in the last segment and reabsorb more water, like I said, under the influence of antidiuretic hormone in these last two segments. So we see more reabsorption there. Here, the distal convoluted tubule on the right side, we see more reabsorption of water, bicarbonate ions, sodium chloride, and more secretion possible there, potassium and hydrogen ions. And then on the last segment here is where we do our reabsorption of water under the influence of hormones, reabsorption of sodium, like the aldosterone we talked about before. If we need to reabsorb more sodium to help with the water reabsorption, then that's where some of that urea is back in as well. So I like this figure because it helps to remind you about all the different segments of the nephron, which all of them are important, and what's going on in each segment. So the critical thing that we have to remember here, when we're talking about the kidney and how it works, is that we have three processes: filtration, reabsorption, and secretion. So you need to know those three. You need to know where in the nephron each of those occurs, or at least have an example of it, right? And then also have an example of a molecule or ion that is moved in those different ways. Name something that's filtered, name something that's secreted, name something that's reabsorbed, and where is that occurring? Okay? Certainly the toxic molecule field does a lot of that. We know filtration only occurs where? Where's that filtration first occur? Only place it occurs. In the glomerulus. So this is the place where filtration occurs. It doesn't show up in the figure, but that's the only place filtration occurs. Water gets filtered, sodium gets filtered, glucose gets filtered, all these small things get filtered out, collected in that cup, in that glomerular capsule, and then we got to start pulling things back, like we see in all these other future segments. Okay? Okay. So what that gives us is that ultimately we produce a urine that its concentration and composition is going to change from time to time depending on the bodily needs, right? Sometimes it's going to be more concentrated, lower volume, like if we're dehydrated. Sometimes it's going to be high volume and very low concentration, right? If it's clearer, right, it looks like water, that's because it has more water in it and less of these different solutes comparatively. So usually urine is about 95% water, and then it contains these other types of molecules and ions as well. Now, luckily, in terms of the system, we've now gone through the tough part of the system, the kidney, doing all the work of this urinary system, because the other tubes and the bladder and stuff like that are really just either routing it to a particular place or holding it temporarily. Okay? So when we do this, if you will, P pathway, if you were doing a tracing for this, and we said, trace a molecule of water from the time it gets filtered out of the blood until it enters the toilet, what you do is you start in that nephron, right? Because filtration occurs in the glomerulus, and that water gets filtered out of the glomerulus and gets caught by the glomerular capsule, then you go into that optimal convoluted tubule, go through that loop, go through that distal convoluted tubule, go through that tree-like collecting tubule, and then from there, it's going to start going to exit the kidney. Now, inside the kidney, we have what's called a renal pelvis. Let's see if we can, I don't know if we can see it anywhere later here. But the pelvis that we have, which is right there, is a collection area. It's kind of like a big funnel. Because all around the periphery, the cortex of the kidney, where all the nephros are doing the job. So then all that urine that's being created has to be collected. So it's going to collect in the renal pelvis. That's drained into the ureter. The ureter is taken down to the bladder. Bladder stores it temporarily. And then at a convenient time, the urethra is going to drain. So that's the whole tracing. You start microscopic with what's going on in the nephron. And then it's going to drain from the kidney, down from the bladder, and out the bladder. Okay? Okay, so like I said, these other structures are pretty simplified. So the ureters are muscular tubes going from the kidney to the bladder. They have 3 layers to them. They're also going to have a mucus lining because ultimately that passes to the outside. They're going to have a muscular middle layer, which is kind of interesting. On a certain level, you just kind of expect it's like a straw, right? In the drain, the kidney makes the urine and blows it down into the bladder. And that's true. There's going to be hydrostatic pressure pushing it. But what if you were like, over in Chandler, during that trapeze school, like they didn't have that actual trapeze school in Chandler. Like you can go on like high trapeze and like learn how to do that, have the net numbers and stuff like that. So what if you were going there and you were swinging upside down? If it was a straw like that, and you swing upside down, all that fluid in the bladder, whoosh, up the kidney, and you'd have a lot of pain, which would be very bad. So there's ways that the system has to make sure that it's kind of a one-way flow, a bit like some of the other fluid systems we talked about before. So when the ureters come down the bladder, they insert along the back side and they form almost a valve right there. So once it goes into the bladder, it can't usually go back into the ureters. Plus, like I said, they have a muscular layer in the middle. So remember how the digestive system has a smooth muscle, so that when it goes peristalsis and it squeezes things down. The ureters actually do that as well. So not only will it go down because there's more fluid pushing it down, but it will be squeezed down on a regular basis to make sure it's going from the kidney down to the bladder. Okay? And if you've ever had a kidney stone or something like that, that that's where the pain comes in, because the kidney stone will often get locked into your. And so not only are you creating a pressure backup, all that new fluid showing up behind it, but now that muscular code is trying to squeeze, normally just squeezing fluid, not squeezing underneath that rock or that crystal. So you can imagine there's a lot of pain associated with that. Okay. So ureters, like I said, we're going to take that ureter down to the bladder, and then the bladder is going to store it. Now the bladder has a triangular shape area called the trigon, where the two ureters come in and the urethra drains. Okay, you'll see that like on the model, those pictures of the model. It also has layers to it, like we talked about, like the ureters do. It's got a mucosal line on the inside. It actually has a submucosa in this case, and a muscular layer, and then an outer serous layer. The protrusive muscle is the middle smooth muscle layer. And that way, what we can do is it's like if you have a boba bag or something like that, right? Or you're drinking out of a wine bag, a wine box. We can usually squeeze the bag in order to get that extra fluid out. And so the flat is like that as well. Certainly, if we open up the urethra, it can drain naturally. But by squeezing with that smooth muscle layer, we can make sure that the bladder will get empty. Okay, so that's called in essence the muscular coat that's in the middle with that protrusive muscle. So here's that triangular area like I was talking about, right? The trigon right there. So you can see it's made by the opening of the urethra and the draining of the opening of the ureter and the draining of the urethra down below. Now, here's a good question for you. So we see the bladder here, and we see the ureter coming down. And here's the urethra draining the bladder. So this is a male or female urinary system. It's a male urinary system. Why? Because there's a prostate gland right there. Okay? So it's carried right. So the male urinary system, as we'll see when we get to the reproductive system very soon, is that the male, we have an overlap, direct overlap between the urinary and the reproductive system. Okay? So they use the same urethra as the body. It's a bit like the beginning of the respiratory and the digestive system, which are shared pathways. But the female is going to be totally separate. So that urethra is going to pass through the prostate, and then it's going to pass through the other sections of the urethra before it exits the body. Okay? Alright, so we'll see some other views and talk about these other organs of the reproductive system coming up. Okay, so that maturation is the process of emptying the bladder. So this reflex involved in that we're going to cause this smooth muscle to contract, and there's luckily going to be two different procedures, two different bands of smooth muscle that are going to control the draining of the bladder. There is the smooth muscle band that is on the inside, right? So this one is going to be under our autonomic control. So when the bladder gets full, this one's going to want to loosen in order to drain, right? Because that's what the body wants to do. It's the full, let's get rid of it. But luckily, we also have an external urethral sphincter, which is skeletal muscle. And we know skeletal muscle is voluntary muscle, so you have voluntary control of that one, so that you can pee at the break as opposed to right here in your seat right now. Okay, so that's very, very good. So anyway, this is going to be controlled by brain and spinal cord, as most of these different reflexes and control systems are. And we're going to be able to do so, though, and control the system at a conscious level as well. We're going to feel that stretch from stretch receptors to the bladder wall, but we're going to be able to control when we actually empty it. So the urethra, like we talked about, between the male and female, is going to convey the urine to the outside in both of them. And the male also is going to conduct semen. The sperm causes secretion out. It's also going to be a muscular tube lined with a mucus lining because it opens to the outside. Okay? So, like I said, those other organs associated with the urinary system are pretty simple. They're just moving the urine, restoring the urine temporarily. I mentioned things like kidney stones. Kidney stones can form for a number of different reasons. They go often, once upon a time, they used to recommend big diet changes if you were getting kidney stones. Most of the kidney stones are calcium-based, calcium oxalate, so they say, you need to cut down the amount of air you're taking in, because obviously that's coming out in your urine, etc. But most people aren't eating like straight cheese meals, etc. So most people have a fairly balanced diet, so changing that influence probably will have more dietary problems rather than a solution for the kidney stone. So these days, as an ongoing treatment, one of the things they do is they'll give you a diuretic. So it's an anti-diuretic hormone, we know each hormone. A diuretic is going to make you pee more, like I said, like alcohol, the effect of alcohol or caffeine. But the idea there is that if the diet, for whatever reason, is coming together and forming crystals, because they're sitting in the fluid too long, the more you flush that fluid out, the less time they have to come together and form crystals so you can get them out before they actually form crystals and form stones, etc. So it doesn't solve the root issue, but it's flushing it out before it becomes a problem. Now, if you develop kidney stone, one of the most common ways they treat it is called lithotripsy. So lithotripsy stone, and so lithotripsy, what it's doing is it's delivering shock waves, sound waves, that are very focused on the stone itself. So what they can do, this is basically outpatient now. They can take this machine and they can wheel it into your doctor's office in like an empty room or something like that. They can do it in just a couple hours while you're in the office. And it doesn't involve surgery or anything like that. They are able to image your kidney. They can do it in an ultrasound or X-ray or whatever to see where the stone is. And then they have this head for the unit that they put right on your kidney. They position it just to where it's delivered right on the stone. And they deliver these ultrasonic blasts. And it tends to break the stone up with these shock waves. Now, it depends on how many stones you have, how big they are. They're only going to deliver so many kind of shocks or hits to your kidney, because as you imagine, even though it's very focused, as stones start to break apart, it does do some damage to the kidney tissue itself. So they don't want to deliver too many shocks to the kidney before they get the kidney to heal. So if you have a lot, they may make a round, and then they may have to come back to the second round, etc. But if it pulverizes it into hopefully a nice small band, if you will, that can easily pass through the bladder, through the urethra. But it's a much better way than some of the other ways they have to do it. Like if you have really big stones, or that's not working, then either they get surgery, they basically take the stuff back, the kidney comes close to your body wall. So if they get surgery, they can go in there, and they can go in and grab them, and then pull them out. That's the shortcut. Otherwise, you go the long, natural pathway to get up to the kidney instead. I don't know really which one's worse, So, anyway, it's not long. We just get kidney stones. Those that actually say that the pain rivals childbirth. Does that mean you're going to do the same thing? They're very big thing. You're trying to remove it through a very small hole. It's not very comfortable.